Welcome back to my channel. Today we are going to start chapter 4, which is endocrinology of the MRCUG 550 SBAs, and these are also MCQs as well. So let's start with the question number 1 concerning the thyroid function during the pregnancy. These are the true and false. Okay, true and false. Before doing the true and false, let's see the explanation that what are the thyroid hormone, and what are the thyroid functions. It's not regarding the thyroid hormone but the thyroid functions. Okay, the pregnancy hormone is the beta HCG hormone, and beta HCG hormone, it is a glycoprotein which is thought to have the thyrotrophic activities, because it also have the subunits which are similar to the thyroid hormone. This may cause some increase in the thyroid activity, such that they can lead to the increase in the thyroid activity, and as well as they lead to the reduction in the TSH hormone, and thyroxine binding globulin. The thyroxine binding globulins, they are going to be increased in pregnancy, and they are responsible for binding thyroxine in the circulation, and along with the transthyrine and albumin, and hyperemesis gravidarum. Hyperemesis gravidarum, it is a very common condition of early pregnancy, and it is associated with the rise in the beta HCG. It is associated with an abnormally high levels of free thyroid hormones. Along with the raised beta HCG, it can also be involved with a high level of free T3 and T4, the thyroid hormones, and reductions in the TSH hormones, and therefore thyroid function tests should be performed in a woman presenting with the condition. So let's see our option. Option number A, beta human chorionic gonadotrophin is partially thyrotrophic. Yes, the beta HCG is considered to have a thyrotrophic activity, and option B is there can be reduction in the thyroid stimulating hormone during the first trimester. Yes, that is also true. It can lead to the reduce in the TSH and raise in the TBG and T3 and T4. And there is option C, there is increased thyroxine binding globulin. Yes, that again it is true. And then hyperemesis gravidarum. Hyperemesis gravidarum, it is associated with abnormally reduced levels of the T3 and T4. No, this option is false, because we have discussed that they can lead to the abnormal reduction of the T3 and T4. And option E, and there can be the 30 to 50% increase in the T4 production during the pregnancy. Yes, that is also true. So option A is true, option B is again true, option C is again true, option D is false, and option E is again true. Okay, now let's move to the next question. That the question is the parathyroid hormone. Before going towards the parathyroid hormone, let's see the simple explanation for the parathyroid hormone. We all know that the parathyroid hormone, they are the polypeptide hormones. They are polypeptide hormones, and they are secreted by the chief cells of the parathyroid gland. And we all know that there are the two pairs of the two on each side of pairs of the parathyroid gland on the thyroid, and they are developed from the pharyngeal pouches during the embryonic development. And the superior glands, they develop from the third pharyngeal pouch, and the lower glands, they develop from the fourth pharyngeal pouch. They are located under the capsule at the posterior area of the thyroid gland, and the blood supplies through the thyroid arteries. And the gene for the parathyroid hormone is located on the chromosome number 11, and with the parathyroid hormone being synthesized as a large prohormone of the 115 amino acid, it is cleaved to give biologically 84 amino acid peptide, and then it is stored in the Golgi apparatus of the cytoplasm of the cell. Now let's see our options. Option number 1, there are the six parathyroid hormone. That is false, because we have 4 parathyroid hormones. B, parathyroid glands, they develop embryologically from the pharyngeal pouches. Yes, that is true. And the blood supply to the parathyroid gland is from the parathyroid arteries. No, they are from the thyroid arteries. And parathyroid hormone is synthesized by the chief cell. Yes, that is true. And the gene of the parathyroid hormone is located on the chromosome number 11. Yes, that is again true. Now let's move to the next question. With regard to the prolactin, now we have we'll see the prolactin hormone. um, Prolactin, it is a long chain polypeptide. Yes, all the hormones, they are the polypeptide in nature. And same as the prolactin, it is also a long chain polypeptide hormone. It is produced by the anterior pituitary. We know that the anterior pituitary secretes a prolactin hormone, and it is responsible for the lactation. The milk ejection reflex is caused by the oxytocin and produced by the posterior pituitary, and in response to the suckling, right? One thing you should remember here, that the prolactin, it is secreted from the anterior pituitary, and oxytocin, it is from the posterior pituitary. Prolactin is for the production of the milk, and oxytocin is for the ejection of the milk. Prolactin is released from the anterior pituitary gland in response to the thyrotrophin releasing hormone, and dopamine is an important inhibitor for the prolactin release. And levels of the prolactin, they may be found to be raised in a primary hypothyroidism as a result of the increased uh, thyrotrophin releasing hormone. And the levels of the prolactin, they reach a peak in the bloodstream approximately 30 minutes after the onset of the suckling. Prolactin, they shows the diurnal variations, and the levels are very high in the evening and the sleeping. Now let's move towards our options. Option number 1, it controls the milk ejection reflex. That is false, because we know that it controls the milk production, and it is released from the anterior pituitary gland in response to the dopamine. Yes, this is very tricky. This is a tricky thing, that because we know that yes, it does release from the anterior pituitary gland, but it does not release in response of dopamine. Dopamine is an inhibitor, but it is released in response of the thyrotrophin releasing hormone. Now, third, it is a peptide comprised of the 198 amino acid. Yes, that is true. It is comprised of the 198 amino acids, and levels, they can be raised in a primary hypothyroidism. And the option D is again true. Yes, we know that. And option E, levels, they can rise after an epileptic seizure. No, yes, that is again true, because the level of the prolactin, they can be raised against the epileptic seizures. Now let's move toward the next question. Considering the anatomy Concerning the anatomy of the thyroid, here the anatomy of the thyroid is very important, and let's discuss the anatomy of the thyroid gland. The development of the thyroid gland is at approximately 24th day of 24th day of fertilization, and the 24th day of fertilization is 3.5 week. 3.5 week. And the thyroid hormones, they are secreted by the fetus by the 11 weeks of the gestation, and thyroid hormone start working at 11 week of the gestation. And the thyroid, it descend into the neck. First, the thyroid, it travels through the neck as a thyroglossal duct, in the form of the duct, and and is formed by the fifth and sixth week of the development. The inferior thyroid artery, it provides the main blood supply. It is the inferior thyroid artery which supplies the main blood supply, and the thyroid glossal duct, it connects the thyroid gland to the tongue during the embryological development, and it is a remnant of this structure that may cause the thyroglossal duct in the later life. Now let's move towards our option number A. It descends in the neck as a thyroglossal cyst. Yes, that is true. And it is formed by the third to fourth week of the development. Yes, that is again, it is formed. It is the development, they start at the 24th day of the gestation. And we can say that it is formed by the third to fourth week of the development, not completely formed, but here we will say that it does not form complete by third and fourth week of the development, but the completion when the thyroid starting production, that is by the 11th week of the gestation. Hence the answer will be 11th week of the gestation. C cells are derived from the fifth arch. Yes, that is true. True. The C cells are derived from the fifth arch, and the isthmus, they lies on the tracheal ring 2 to 4. Yes, that is again true. And the main blood supply is from the lateral thyroid artery. No, we have just discussed that it is the main blood supply is from the inferior thyroid artery. Let's move towards the Graves' disease. The Graves' disease, it is an autoimmune disease which is caused by an immunoglobulin G IgG autoantibodies against the thyroid receptors, like the thyroid receptors, which acts as the thyroid stimulator and lead to the excess production of T4 and T3. This auto antibody, they has a binding site separate to the thyroid stimulating hormone but changes the shape of the receptor. The sign and symptoms are those associated with the hyperthyroidism, because in this disease primarily that in the Grave disease, they form the antibodies which act act on the receptors, and these antibodies, they are going to fix here, and this lead to the production of the increased T3 and T4, T4, and thus the patient will get the symptoms of the hyperthyroidism and hyperthyroidism and but the pretibial mixed edema and the exophthalmos are very common to the Graves disease. Pretibial mixed edema, they occurs in approximately 1 to 4% of the cases with the Graves disease and appears in an indurated colored region at the lower anterior leg, and as the autoantibody is IgG, it is able to cross the placenta and may lead to the fetal thyrotoxicosis and goiter. 95% of the cases of hyperthyroidism in pregnancy, they are caused by the Graves disease. Other causes of hyperthyroidism in the pregnancy, they includes the toxic thyroid adenoma or the toxic multinodular goiter. So let's move towards our option. It is caused by IgM antibody against the thyroid stimulating hormone receptor. No, false. These are the IgG antibodies. It is a form of the hypothyroidism. No, it is a form of the hyperthyroidism. Pretibial mixed edema is present. Yes, in 1 to 4 cases pretibial mixed edema, they can be present, and it does not affect the fetus. No, as they are the IgG antibodies, they can pass the placenta and they do affect the fetus. And end of thalamus, they can be present. No, in the Graves disease, there is exophthalmos is more common than the end of thalamus. Now let's see what does cortisol has to say. And cortisol, it is a glycoprotein. We know that the cortisol, it is a glycoprotein, and this glycoprotein it is produced from the zona fasciculata of adrenal gland, and it is transported bound to the cortisol binding globulin and the albumin. The remaining 5% of the hormone is free. It has the circadian rhythm with the highest production at 8 a.m. and the functions of the cortisol are important for the metabolism of carbohydrates, proteins, and fats. And cortisol suppresses the immune system, and this is important to remember in those patients that are on the long-term steroid replacement therapy. The overall action of the cortisol is to increase the blood glucose level. The actions of the cortisol say includes the immunosuppressive and the anti-inflammatory and increased lipolysis and increased gluconeogenesis and glycogen storage in the liver, and breakdown of the skeletal muscles and metabolism of the mobilization of the amino acids. So let's move towards our option. And option number 1, it is produced by the zona fasciculata of the cortex. Yes, that is true. Yes, that is true. And then the majority is transparent in the plasma bound to the albumin. No, that is false, because the majority is transported through the cortisol binding globulin 80% of the cases, and but in the 15% of cases it does travels via the albumin. Production has a circadian rhythm, the highest production at night. No, that is the highest production is, yes, there is a circadian rhythm, but the highest production is at 8 a.m. in the morning. It is derived from the cholesterol. Yes, that's a cortisol hormone is a steroid, and steroids have a precursors of the cholesterol. It is a mineralocorticoid. No, it is not a mineralocorticoid, but glucocorticoid enzyme. Now let's move towards the next question regarding the renin angiotensin aldosterone system. The renin angiotensin aldosterone system, it is activated when there is a whenever there is a reduce in the blood pressure. The renin angiotensin aldosterone system, three things: renin angiotensin aldosterone system, they get activated whenever there is a decrease in the blood pressure. It is this decrease in the blood pressure, it is detected by the baroreceptors. These baroreceptors, they are located in the carotid sinus. They are present in the carotid sinus. A decrease in the filtered sodium concentration, this stimulates the macular dense of the kidney to release the renin. Another thing, when there is a decrease in the reabsorption of the sodium, it will lead to the increase in the productions of the renin in the kidney from the macular dense of the kidney. A reduction in the perfusion of the juxtaglomerular apparatus, its decreased perfusion, they also lead to the release of the renin. This renin then acts on the angiotensin. This renin, it is going to act on the angiotensin angiotensinogen, and this angiotensinogen, it is cleaved to inactive peptide, lead to the formation of the angiotensin 1. And angiotensin converting enzyme, which is also known as the ACE, is produced in the lungs, acts on the angiotensin 1. This ACE enzyme, here they will come the ACE enzyme, this will act on the angiotensin 1 and convert it into the angiotensin 2. This angiotensin 2 enzyme is a vasoconstrictor of the arterioles and cause a rise in the aldosterone. It will lead to the raising in the aldosterone, and the overall effect is to increase the blood pressure. Okay, let me summarize this for you again. Listen, whenever there is a decrease in the blood pressure, how you are going to know that there is a decrease in the blood pressure? These are the baroreceptors which are present in the carotid sinus, which detect that whenever there is a decrease in the blood pressure. And when there is a decrease in blood pressure, it will lead to the decrease sodium reabsorption and decreased juxtaglomerular apparatus perfusion. And when they detect that there is a decreased sodium reabsorption and there is a decreased juxtaglomerular apparatus, they will lead to the production of renin. This renin is going to act on the angiotensinogen and convert it into the angiotensin 1. And then ACE enzymes, which are from the lungs, they act on the angiotensin 1, and they are going to convert this angiotensin 1 into angiotensin 2, and this angiotensin 2 is converted to the aldosterone, and then together they act to normalize the blood pressure. Now let's see our options. Regarding the renin angiotensin aldosterone system, the renin is secreted from the juxtaglomerular apparatus of the kidney. Yes, that is true. And renin stimulates the productions of the angiotensinogen from the angiotensin 1. That is also true, that they are going to increase the production of the angiotensinogen, which lead to the increased production of angiotensin 1. Okay, here just stop, because we have seen if you reread the option, you will come to know that the production is not from the angiotensin 1, but it is from the it is the angiotensinogen which is converted to angiotensinogen 1. So this option is false. Angiotensin 2 stimulates secretions of the aldosterone from the adrenal medulla. Yes, adrenal medulla. Yes, do angiotensin 2 ये do stimulate the secretion of the aldosterone, but it is not from the um, 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 from the adrenal medulla. So the option will be the false. Then angiotensin converting enzyme, they converts angiotensin 1 to angiotensin 2. Yes, that is true. And low blood pressure detected by the sinus carotid chemoreceptors, they activate the RAS. Yes, that is again true. Now let's move towards our next question. This is the Addison's disease. Addison's disease, it is also known as primary primary adrenocortical insufficiency. Primary adrenocortical insufficiency, it has an increase incidence of approximately 0.8 to 100,000, and 80% of the cases, they are the result of the autoimmune disease. 80% of the cases are the autoimmune disease, and may be associated with other autoimmune conditions such as the Graves' disease, pernicious anemia, and diabetes mellitus. Symptoms, they include the fatigue. The most common symptoms are the fatigue, abdominal pain, and the non-common are again the nausea, the vomiting. Adrenocorticotrophin hormone, ACTH, it is the ACTH, adrenocorticotrophin hormone, ACTH produces by the pituitary gland, is responsible for the pigmentation seen in this condition. And as levels are higher than the normal, the classically there is a hyponatremia and hyperkalemia, and they may lead to the associated ECG changes, because there will be the hyponatremia, decrease in the sodium levels, and hyperkalemia, increase in the levels of the potassium. So let's move on are the options. Regarding the Addison disease, it has an incidence of approximately 1 in 1000. Yes, that 100,000. Yes, that is true, because it is 0.8 to 100,000, 0.8 in 100,000, and it can be misdiagnosed as anorexia nervosa. Yes, that is true, because the patient has the symptoms of the nausea and vomiting, fatigue, and abdominal pain, and patients, they may have the hyperpigmentation. Yes, that is again true, because this hyperpigmentation is due to the adrenocorticotrophin hormone, which is produced by the pituitary gland, and it is responsible for the pigmentation, and is associated with the hypokalemia and hyponatremia. No, it is false, because it is associated with the hyperkalemia and hyponatremia, and it can be caused by the Waterhouse-Frederick syndrome. Yes, that is true. It can be caused from the Waterhouse-Frederick syndrome. Now let's the pheochromocytoma. The okay, let's you might have thought, what is the Waterhouse Frederick syndrome? The Waterhouse Frederick syndrome, it is a hemorrhage in the adrenal cortex. It results as a result of the fulminant meningococcemia. Other causes of adrenal hemorrhage, it includes coagulopathic state, shock, and pregnancy associated causes. Now let's move question number 9, the pheochromocytoma. The pheochromocytoma, it is a catecholamine. It is a catecholamine production producing tumor. It is such that the high levels of the catecholamine tumor of the neuroendocrine cells of the adrenal medulla. It is a rare cause of the hypertension, being responsible for the approximately 1% of the cases. It may be autosomal dominant inherited condition. Most pheochromocytoma, they are found unilaterally in the adrenal medulla. Symptoms, they may include headache, a sense of the impending doom, and associated with increased blood pressure. Multiple endocrine neoplasia is a group of the genetic tumor syndromes. Pheochromocytoma is found in the multiple endocrine neoplasia 2A, and along with the medullary thyroid cancers and the parathyroid hyperplasia. Men 1 comprises the parathyroid hyperplasia, pituitary adenoma, and pancreatic tumors. Treatment, they can be surgical or metrical. However, blood pressure control is usually necessary prior to operative management. Alpha blockage is given by the phenoxybenzamine, and 24 hours later, cardioselective beta blocker is given. Now let's see our options. and pheochromocytoma is a cause of hypertension in less than 1% of the cases. Yes, that is true. It has a triad of the symptoms: the sweating, palpitation, and headache. Yes, that is again true. And it is linked with the carne complex. Yes, that is true. And it has an association with the multiple endocrine neoplasia 1. No, it is more like associated with the man 2A. And treatment is with the cardio selective beta blocker, followed by the alpha blocker, phenoxybenzene. No, the treatment, it is mostly surgical or medical, but the blood pressure is usually controlled before any operation. Alpha blockage is given by the phenoxybenzamine in 24 and 24 hour later cardioselective beta blocker is given. So this option is false. Now let's move towards our next question, that is the functions of the insulin. The functions of the insulin, in overall, the function of the insulin is decreased hepatic output of the glucose. This occurs this occurs by either by the there is a promote glycogen synthesis, such that increase glycogen synthetase, and inhibit the glycogen phosphorylase, or decrease gluconeogenesis, or suppress the lipolysis, inhibit the triglyceride lipase, and increase the fatty acid synthase, and suppress the ketogenesis, inhibit the carnitine palmitoyl transferase, or increase acetyl coenzyme A carboxylase. Let's see our options. It increase in the lipolysis. No, we have just discussed that it decreases the it suppresses the lipolysis. It decreases the gluconeogenesis. Yes, that is true. It decreases the gluconeogenesis, and it increases the glycogen synthase. Yes, that is again true. And it suppresses the ketogenesis. Yes, that is again true. And activate the glycogen phosphorylase. No, that is false, because it inhibits the glycogen phosphorylase enzyme. Now next question regarding the estrogen. Estrogen, there are the three main estrogens: the estrogen E1, which is known as the estrone, then estrogen E2, that is estriol, and then E3, that is estradiol. That is estradiol. Osteron is the main estrogen postmenopausal pause. This is more in the menopause women, and E2 is more in the fertile female, and estradiol is more when the patient has the pregnancy. So let's see our options. Option number 1, the main estrogen after menopause is estrione. Yes, that is true. The main estrogen between puberty and menopause is estriol. Estriol between the puberty and menopause is estriol. No, between the puberty and menopause it is estradiol. It is estradiol, so this option will be false. And aromatase converts the testosterone or to estradiol. Yes, that is true. Estradiol is weaker than esterone. Estrone, no, that is false. And androstenedione is converted to estrone. Estrone, yes, that is true. Now the ovarian steroidogenesis. The productions of the steroid hormone is by the ovary, depends on the menstrual cycle. Progesterone is produced by the ovarian theca, and the theca and granulosa cells, they produce the progesterone, and it is mainly present in the luteal phase of the menstrual cycle. During the follicular phase of the cycle, it is mainly estrogen that is produced. Testosterone is produced by the theca cell only. The theca cell, they produce the testosterone only. And estradiol, the end product of the steroidogenesis, is produced only by the granulosa cells. Estradiol granulosa cell. The In the ovarian follicle, the theca cells, they have the receptors of the luteinizing hormone and non stimulating and not the follicular stimulating hormone. The theca cells, the theca cells, they have the receptors of the luteinizing hormone, and granulosa cells, they have the receptors of the FSH and LH as well, but on later on. Let's move to the options. Option number one, the progesterone is produced by the ovarian theca cell only. No, it is produced by both theca and granulosa cells. Testosterone produced by the ovarian theca cells only. Yes, that is true. Yes, that is true. And the next question is, estradiol is produced by the ovarian granulosa cells. Yes, that is again true. True. And theca cells, they have the follicular stimulating hormone. No, theca cells, they have the luteinizing hormone receptor, so this option is false. Granulosa cells, they are responsive to the FSH and luteinizing hormone. Yes, that is true. And so I'm going to end my lecture here, because recording is almost 30 minutes, so I want to keep my lectures short, so that you may not get bored and you may understand all the things. If you have any questions, you can comment me and I'll answer you personally. And till that time, take care, bye bye. But before that, if you really like the video, then do like it and hit the subscribe button and share it to your friends. Take care. Bye bye.